Good morning, everyone. I am presenting on behalf of Medicine Pi. The topic is mimic. Mrs. X, 50 years old teacher from Kolkata, presented with weakness of both upper limbs and lower limbs for 2 years and exceptional dyspnea for 2 years. The history of presenting illness, she was well before 2 years, then developed insidious onset, gradually progressive weakness of both upper limb and lower limbs. She had difficulty in getting up from squatting position, climbing stairs. Also, she had difficulty in turning sideways in bed. However, there was no difficulty in walking on her heels or toes. She also had difficulty in overhead activities. Subsequently, she developed difficulty in bringing food to her mouth and difficulty in combing hair. However, there was no difficulty in holding objects or writing. There is no history of easy fatigability or diurnal variation. Regarding exceptional dyspnea, the exceptional dyspnea, she was well before 2 years, then developed insidious onset, gradually progressive dyspnea, which is initially of grade MMRC grade 1 to MMRC grade 3, which was associated with a dry cough. However, there is no associated chest pain, palpitation, syncope, no orthopnea, PND. There is no history of any seasonal variation in dyspnea, no occupational exposure, no dust allergy, and there is no biomass exposure. There is also no history of any Raynaud's phenomenon, oral ulcers, photosensitivity, dysphagia, or Zika symptoms. Past history, there is no, she had no comorbidities. Personal history, she is a post-menopause lady for 7 years. Consumes mixed diet, sleep was normal, her bowel and bladder habits were normal. Family history, there is no family history of malignancies. Examination wise, vitals, her blood pressures were 110/70, pulse rate of 90 per minute regular, all distal pulses were palpable, the respiratory rate of 20 per minute. General examination showed a positive finding of pallor. There is no clubbing, cyanosis, lymphadenopathy, or edema. There is no skin thickening noted. Bilateral breast examination showed no mass palpable. This is her palms. Her examination, they showed some hyperkeratotic plaques and multiple fissures at the tip of her fingers. Her respiratory system examination, trachea was in midline, symmetrical chest rise is noted. There was late inspiratory crepitation bilaterally here. CVS examination was normal. Abdominal examination was also normal. Central nervous system examination, the bulk was normal. Her tone was decreased bilaterally. Shoulder power in abduction and adduction was decreased bilaterally 3/5. Elbow power is 4/5, and rest both flexion and extension by 5/5. Hand grip was good. Hip flexion and extension was decreased 4/5 bilaterally. Knee and angle power were normal. Sensory system examination was normal. Reflexes were preserved in both superficial reflexes and deep tendon reflexes were preserved. Bilateral plantars were flexes, and there is no other significant findings. Summarizing, a 50 years old female with no comorbidities in the past. Now she has come with a complaint of pure motor proximal weakness with the exceptional dyspnea and examination findings of late inspiratory crepitation and hyperkeratotic plaques and fissures over her form. The differential at this point we consider where the pure motor proximal myopathy with probable interstitial lung disease, and the differential probability of mechanic hand we have considered because of their hyperkeratotic plaques. The differential we consider at this point where inflammatory myositis, considering age and age, we even thought of a paraneoplastic endocrine myopathy like hypothyroidism. So how did we approach this weakness? So every weakness we'll ask, we can categorize it into either UMN versus LMN. In our patient, examination showed a mild decrease in tone with a decrease in power with the normal reflexes and normal reflexes, pointing towards more of a LMN weakness. LMN weakness we can categorize based on, it can be either at the level of a root, it can be level of a plexus, nerve or neuromuscular junction and muscle. Usually the root weakness, it will be asymmetrical, and the pain and weakness will be along at the site dermatome and myotome. If the lesion is at the level of plex, it will also be asymmetrical, with most likely sensory motor and distal and proximal weakness will be there, because the nerve roots involved, every nerve roots will have the weakness. If in case only nerve is involved, it will can be symmetrical as well as asymmetrical. the weakness will be most of a distal, and sensory symptoms will be there. And reflexes can be either absent or diminished based on the large fiber neuropathy or large fiber and small fiber neuropathy. In case of neuromuscular junction lesion, there will be fatigability, diurnal variation. And in case of limited to muscle, there will be proximal more than distal weakness, and the sensory system will be normal and reflexes will be preserved. In our case, the patient had more of a proximal weakness with a preserved sensation and preserved reflex, pointing towards more of a muscle weakness. So when we have a muscle weakness, we can ask two questions: whether is it intermittent muscle weakness or a persistent muscle weakness. If in case it is intermittent muscle weakness, the differential will be like hypokalemic periodic paralysis, monoclonal mitochondrial myopathy, neuromuscular junction disorders. Our patient had a persistent weakness. There is no waxing and waning of weakness in between. For in case of persistent weakness, based on the pattern of myopathy, we can make the differentials. Like if proximal more than distal, polymyositis, dermatomyositis, anti-synthetase syndrome, muscle dystrophies, mitochondrial metabolic myopathies, endocrine myopathies were the differentials, which in our patient we had more of a proximal more than distal weakness. If there is ptosis and extraocular muscle movement involvement, could be oculopharyngeal muscular dystrophy. In case of facial weakness and scapular winging, it could be facioscapulohumeral dystrophy. If facial involvement along with distal quadriceps and hand grip myotonia, most of myotonic muscular dystrophy. In case of both proximal and distal weakness along with quadriceps involvement, it could be inclusion body myositis. The pure distal, in case if it is distal myopathy, the differentials were distal muscular dystrophy and congenital myopathies. In case if patient had a drop head or axial weakness, could be myasthenia gravis, hyperparathyroidism related myopathy, axial myopathy. But to confirm this, we will do the next investigation, EMG. Myopathic EMG confirms the muscle disease and exclude ALS. In case if you are suspecting NMG, we can do repeated nerve stimulation study, and elevated CPK will support the myopathy. However, the gold standard is muscle biopsy for diagnosis. Investigation for our patient, our CPK was found to be elevated to 7,487. Chest X-ray showed a reticulonodular pattern. We did EMG, which is suggestive of a myopathic process. For evaluation of dyspnea, we did echo. It showed a normal systolic function. There is no evidence of features of pulmonary artery hypertension, and PFT showed some restrictive process. With the reticulonodular pattern in chest X-ray, we did HRCT, which showed features of ILD with NSIP pattern. Further evaluation of now we came to close. We reached diagnosis with inflammatory myositis and interstitial lung disease. Further, an evaluation for the myositis profile found to be PL and antibody strong positive. We even ruled out associated with other systemic disorders like anti-SL70 was negative, ANA was negative, and ELISA anti-RNP was also negative. Now, currently we have a syndrome complex of myositis, interstitial lung disease, probable mechanics hand with a strong PL7 antibody positive, which is favoring towards more of anti-synthetase syndrome. So what is anti-synthetase syndrome? It's antibodies against one of many amino acyl transfer RNA. Clinical features of this anti-synthetase syndrome includes ILD, non-erosive arthritis, myositis, Raynaud's phenomenon, and unexplained fever with mechanics hand. So there are many antibodies against this anti-microacyl transfer RNA. The most common one is anti-Jo1. And other anti-synthetase antibodies were OJ, EJ, PL7, PL12, KS, and HA antigen. This PL7 anti-Jo1 were associated with increased risk of interstitial lung disease. There are criteria for diagnosis of anti-synthetase syndrome. One is Corners and Solomon criteria. The first in Solomon Corners criteria, the required criteria is presence of anti-amino acid tRNA synthesis antibody. With in addition to that, one of more of the following: either Raynaud's phenomena, arthritis, interstitial lung disease, fever, or mechanics. Solomon's criteria is the mandatory criteria is presence of anti-amino acid tRNA synthesis antibody. Either two of a major criteria or one major or two plus two minor criteria. Major criteria is where interstitial lung disease, polymyositis. Minor criteria where Raynaud's phenomena, arthritis, or mechanism, in which our patient had presence of anti-amino acid tRNA synthesis antibody with interstitial lung disease and arthritis, myositis, and mechanics. Treatment of this antisynthetic syndrome is primarily immunosuppressive agents. Usually we start with the corticosteroids monotherapy. However, while tapering, most of the patient will have a lung disease recurrence on tapering steroids. So they may recover adjuvant agents such as azathioprine, MMF, tacrolimus, rituximab, and cyclophosphamide.
Thank you for this presentation. So, how did you treat your patient?
We started 1 mg per kg. We are following.
You are following us. Okay. Any questions? We'll move to the next case. All at once by Dr. Andrew Kevin from Medicine 4.